long-term risk of meningitis, etc. So, so first of all, hearing loss. A lot of times, the hearing loss that is associated with the cerebrospinal fluid otorrhea, or at least cerebrospinal fluid in the middle ear. Oop. Sorry, guys. Richard, are you able to see my presentation?
No, whatever you just touched reversed it back to being kind of screwed up.
I am seeing your presentation, Alex.
Okay, then if you can see it fine, then please go ahead.
Is it now? It's a slide that says spontaneous CSF Leaks presentation.
Okay, are you seeing the whole thing, Nestor?
Yeah.
Okay.
Middle ear effusion now.
Mila, are you seeing the whole screen?
Yeah, I can see too.
Yeah, I can see the whole screen.
Okay,
Okay.
Alex, for some.
Yeah, yeah.
Now
so
is the building.
So you guys
We can
see the
see
whole screen?
Yeah, we are seeing the building now. Yeah.
Okay,
Okay.
Alex.
Yes, we can see it.
Perfect, perfect. Thanks, everybody. Okay, so just a little bit about how sort of I go about the evaluation. So a lot of times in these patients, you'll see a 10 to 20 decibel conductive hearing loss just because of the presence of the middle ear fluid. A lot of these patients will have aural fullness or pressure. A lot of times you'll see this is sort of a constant feeling, not unlike just a run-of-the-mill chronic serous otitis media. That's of course from the middle ear fluid that's present, but also in large part, I think, because of the irritated middle ear mucosa. The middle ear effusion that's present, I think this is probably one of the main differentiating factors. You know, when we see an allergic effusion from, you know, eustachian tube dysfunction from allergic rhinitis, or let's say nasopharyngeal mass, usually that fluid is a kind of amber colored sort of yellow. But in CSF leaks, it's usually a clear fluid. Looks like this picture here. You can oftentimes see little air bubbles, not to be confused with laryngosclerosis or even middle ear adhesions. But this is sort of a classic appearance that you'll see. High up on the list of presenting factors is pressure equalization tube otorrhea, or constant drainage from the ear. This, unfortunately, I often see as a delayed diagnosis, and I think you all can really set yourselves apart from other diagnosticians just because of your suspicion that this may be a process. The longest one that I ever saw was a patient who had been draining for about 6 years. Her previous otolaryngologist had tried ear drops, powders, even tried repairing the small hole after removing the tube. But I think the biggest point to drive home here is just to really have a high suspicion if a patient continues to have a drainage from the ear after appropriate treatment, especially in the absence of any previous otologic otologic history. If somebody's never had ear infections, never had issues with middle ear fluid prior to this beginning, then I think your suspicion has to be pretty high. Meningitis is obviously can be a presenting factor in these patients. I've had a couple of patients who have actually presented with a fulminant meningitis from what was an acute otitis media that spread to the intracranial subarachnoid space, and they developed a meningitis as a result. You have to remember, The most common source of bacterial meningitis is an otologic source or otitic meningitis, followed by, excuse me, followed by sinus infections. The most common bug being Streptococcus pneumoniae. Again, this may be the first presenting symptom in some people, and a lot of times patients will ask, well, you know, what's my risk of getting meningitis? It's a wide range. It's up to 60%, but sort of the general number that I usually tell patients is about 20% risk. And I think that's one reason, of course, other than a chronically draining ear. I think the decreasing the risk of long-term meningitis is important, is a reasonable reason to repair these patients' defects. So at their initial visit, you know, obviously in addition to a history and so forth, I always discuss meningitis precautions. I always like to document that in the chart. I will, in the CDC, the Centers for Disease Control here in the United States, actually recommends, similar to cochlear implant candidates, recommends that patients with cerebrospinal fluid leaks obtain a couple of the pneumococcal vaccines, the Prevnar 13 and the Pneumovax. So I usually will write them a prescription for both of those. I talk about, again, the signs and symptoms of meningitis. Of course, if they develop any of those, they need to go to the emergency room immediately. And then also talk about some precautions to sort of minimize the risk. Avoid vigorous nose blowing and sneeze with the mouth open. These are sort of more than anything risks to lower the risk of pneumocephalus, which I've never seen to a significant degree, but theoretically can reduce the risk of meningitis. So now we'll sort of move on to what are the causes. So those are sort of some of the presenting signs and symptoms, sort of initial diagnosis and so forth. But what are the causes? So there really is no uniform defined cause of spontaneous CSF leaks, but there's certainly a link to multiple different potential etiologies that may sort of coalesce and in combination cause a spontaneous leak. One of these is arachnoid granulations. Dr. Gasik talked about these in the late 90s, published a couple of papers on them. Congenitally thin skull base, especially middle fossa, obstructive sleep apnea, we'll talk about that, sort of the mechanism behind that in a little bit, obesity. And that's bolded because that is really the only sort of firm correlation to spontaneous cerebrospinal fluid leaks. While these other things are potential etiologies and causation or causative factors, obesity is the one thing that has been firmly linked. And then finally, increased intracranial pressure, again, closely tied to obesity, but you know, in the form of idiopathic intracranial hypertension or benign intracranial hypertension. It goes by different names we'll talk about in a minute. So let's talk about the first potential etiology, arachnoid granulations. So the function of arachnoid granulations is basically to resorb cerebrospinal fluid. So the arachnoid granulations or arachnoid villi are sort of these sponge-like little pouches that actually are arachnoid, that they project through the dura and into the lumen of the dural venous sinuses, particularly the superior sagittal sinus. And also the transverse sinuses. And the normal function, again, is to return the subarachnoid cerebrospinal fluid back to the venous circulation. And the way that occurs is because there's a pressure gradient. So there's a pressure gradient from high to low pressure. So it's a higher pressure in the subarachnoid space than it is in the dural venous sinus. So then you get a flow high to low pressure, which causes the cerebrospinal fluid flow gradient in that direction. And a lot of times at the time of surgery, when we repair these, when we actually repair tegment defects or and the dural defects, you can see these arachnoid granulations, and they just look like a little collection of granulation tissue, a pouch, or little fingers, for lack of a better word, that you can see that actually project directly through bony defects in the skull base. So we talked about the function, the location of the arachnoid granulations. I'll show on the next slide, but the arachnoid granulations can enlarge over time, and then you can also get aberrant granulations that again are thought to be partly responsible for spontaneous leaks. And so Gasek again postulated that during development, rather than arachnoid granulations being in the normal location to drain into the venous sinuses, they actually occur and are located over a pneumatized portion of the skull base. And one of these areas that he postulated is sort of lateral to the cribriform plate here in the anterior cranial fossa. And that is obviously where anterior skull base defects that present with cerebrospinal fluid rhinorrhea can arise and present. And we're not going to talk about that, but just to be inclusive, that's one area where aberrant arachnoid granulations can occur. Another location is the floor of the middle fossa, and that's sort of what we're talking about today. So really anywhere from the lateral aspect of the tegmen tympani, the squamosal portion of the temporal bone, all the way medially into the posterior fossa near the sella turcica. And then finally, a third region, which is the least common, is in the posterior fossa between the sigmoid, so the sigmoid sinus and the labyrinth here. You can get some arachnoid granulations in that location. And this is a location where a lot of times, and we'll talk about it later, that you can see failures of repairs that are done only through a middle fossa approach. If you don't adequately identify the posterior fossa defects, then you can inadequately do an inadequate repair and fail to stop a leak. These the granulation, the aberrant arachnoid granulations obviously because they're aberrant, they don't lay adjacent to a dural venous sinus, and therefore can penetrate the dura and create these little pinpoint holes in the skull base that give rise to the leak. And arachnoid granulations can also enlarge, as again with time and age, physical activity. And also transient elevations just in normal daily functions of subarachnoid pressure. And it's this sort of gradual sort of water over a rock to form a canyon that causes erosion of the skull base and ultimately results in a leak. Another cause that we mentioned was just a congenitally thin skull base. And what can happen is just the normal pulsations of the brain with one's heartbeat, cardiac output can erode these congenitally thin areas. And one thing that sort of leads to this hypothesis is that oftentimes in 15% of patients that have tegmen defects of the middle fossa, they also will have an associated superior semicircular canal dehiscence. And we actually just repaired a patient 2 weeks ago who actually had bilateral tegmen defects and bilateral leaks. We repaired one of her sides. She had a superior semicircular canal dehiscence as well. Another etiology, obstructive sleep apnea. So up to 43%, so almost close to half of patients with spontaneous lateral skull base leaks will have associated obstructive sleep apnea. And obviously this goes hand in hand with obesity that we'll talk about in a few minutes. But the apneic events that are associated with obstructive sleep apnea cause hypoxia, hypercapnia, both of which lead to increased cerebral blood flow. Again, why we try to keep patients CO2 low during intracranial surgery to decrease blood loss, and lead to temporary increases in intracranial pressure. And again, it's sort of this feedback loop that, that can then cause further skull base erosion. And this is just a nice flow chart, I think, sort of showing the just a flow sheet kind of diagramming how we end up with a cerebral spinal fluid leak as a result of obesity, and specifically obstructive sleep apnea and IIH. So both of these processes lead to elevated intracranial pressure, whether it's a constant thing from intracranial idiopathic intracranial hypertension, or an intermittent phenomenon arising from obstructive sleep apnea. But again, they both cause elevated intracranial pressure, calvarial and skull base thinning, and then can lead to a cerebral spinal fluid leak. So obesity, this has sort of become my my specialty, not necessarily my specialty, but something that we see quite frequently. I usually will see 1 or 2 of these patients a month, believe it or not. And as I had mentioned a while back, you know, obesity is really the only factor with a known association with spontaneous cerebral spinal fluid leaks. And again, 80% of patients with spontaneous CSF leaks will be overweight or obese. And one study by Nelson showed that there was an increase, a 2-fold increase in the incidence of spontaneous CSF leak repairs. So just the CPT code of CSF leak repair, excuse me, from 2002 to 2012. And that correlated quite directly with the rise in obesity in the United States. And this is just an interesting map that I think can diagram at least this phenomenon in the United States. This is from the CDC, and it shows U.S. adult obesity rates in the United States by individual states. And again, we have to remember the BMI is calculated by kilograms divided by meters squared. And sort of the rough, categories, any BMI from 25 to 30 is considered overweight, and anything over 30 is considered obese. So you can see back in 1990, the United States was doing pretty well. We didn't have anybody even in the yellow category. In 1995, you can see now we're sort of more states, but we're still in the green. In 2000, the rate of obesity and people being overweight continues to increase. Now we have a majority of the states are in the yellow category, or 20 to 25% BMI. We continue on 2003. Now we're starting to get up into that obese area, sort of here in the eastern United States. 2004, 2005, 2006, we kind of have our pop up with Mississippi as the first morbidly obese state. 2007, again, you can see now we're only one state is in the yellow, is in the green, and everything else is approaching the obese category. 2009, 2010. So here you can see now in the southern states, Oklahoma, where I am, is one of them, are now have 30 to 35% of patients that are obese. 2012, again, we're still just percentages again. Now we're up to 35% or more of patients that are obese. So they're in that greater than 30 BMI category. 2014, 2015, 2016, 17. And so you can see in 2017, we have a handful of the southern states, Oklahoma being one of them, where 35% or more of patients have a BMI of greater than 30. This is just sort of a graphical representation of it. And you can see Oklahoma is again, 36.5% patients that are greater than 30 BMI. The United States as a whole, where do we stand? We're actually 12th. Believe it or not, I thought we would be higher, but a lot of these countries are known for sort of body habitus of being a little bit bigger. This is the scalp film. So this is just the scalp film in preparation for a CT scan on a patient that we had, and you can just tell her body habitus, how thick her neck is, how big her shoulders are. And this is just sort of a just a representation. You can get a rough feeling for just the body habitus of a patient just by looking at their scalp film. So what is the role of obesity? This is a nice just sort of flow chart that shows sort of the feedback loop that can be created by obesity. So what obesity triggers an increase in abdominal pressure, and that increase in abdominal pressure then leads to an elevation in thoracic pressure, which then causes a decrease in the venous return to the heart, and the decreased venous return results in elevated intracranial pressure.
سلام عليكم الحمد لله ما شاء الله خير الحمد لله.
So this is just a quick slide to discuss some terminology. It can be a little bit confusing when you review the literature, especially older literature, where idiopathic intracranial hypertension is I think the preferred term in today's literature. It's often used synonymously with pseudotumor cerebri, but in the 1890s, Quincke he came up with the name of serous meningitis. So it was not necessarily an infectious meningitis, but rather a buildup of fluid causing intracranial issues. Again, pseudotumor cerebri is sort of used synonymously. Benign intracranial hypertension was the term in the 1950s, and it sort of fell out of favor just because this isn't a benign process, right? It can cause CSF leaks, it can cause vision loss, chronic headaches, and so forth. And so it's really not a benign process. So that's why benign intracranial hypertension sort of fell out of favor as a description for this process. And that's sort of where we ended up with idiopathic intracranial hypertension. IIH is at baseline a disorder characterized by increased intracranial pressure. Again, as the name suggests, idiopathic. We don't know exactly what causes it, but we have a couple of causative or at least related factors, and it primarily affects women of childbearing age. And just some numbers to keep in the back of your head. So normal CSF pressure is about 10 to 18 centimeters of water, or 8 to 15 millimeters of mercury. And usually secretion and absorption rates are equal at normal intracranial pressures. So again, that's what keeps the system in homeostasis. So what are the causes? What's the root cause of idiopathic intracranial hypertension? Again, we don't know for sure, but there are some sort of leading candidates or leading etiologies. One of these is cerebrospinal fluid hypersecretion. That seems a bit unlikely to be the cause because hypersecretion of CSF usually results in hydrocephalus or ventriculomegaly, and we don't see either of those in idiopathic intracranial hypertension. A second cause is outflow obstruction. So outflow obstruction or an increased venous sinus pressure. So the two of these sort of go hand in hand. The question is which comes first? So an outflow obstruction can result from either an increase in outflow resistance or a decrease in the pressure gradient between the venous sinuses and the subarachnoid space. Remember, we talked about that pressure gradient which drives the flow CSF from the subarachnoid space through the arachnoid granulations and into the venous sinuses. Some isotope studies have shown that there can be outflow obstruction as a result of the stenosis at the particularly at the transverse sigmoid junction in patients with idiopathic intracranial hypertension. And that stenosis can be either from an intrinsic obstruction because of an abnormality of the sinus wall, or extrinsic, again, from compression of the sinus from underlying elevated intracranial pressure. Either way, the stenosis can result in venous hypertension, which decreases that gradient and decreases cerebrospinal fluid resorption by decreasing outflow as a result of the decreased pressure gradient. Finally, increased venous sinus pressure can be the result of venous sinus stenosis, and this has sort of been the rationale for some patients being undergoing a true a formal angiogram and actually undergoing venous sinus stenting, particularly of the transverse sigmoid junction. And again, that one of the main etiologies of that, of course, would be obesity leading to increased intracranial hypertension. Finally, some researchers think that hormonal and metabolic factors can be one of the etiologic factors. Again, it's primarily a disease of women in childbearing age, and that's so some people think that the hormonal etiology could come from that. Metabolic factors, again, not to belabor the point, but obesity is obviously a metabolic factor, and again, one of the only risk factors that has shown to increase the incidence of idiopathic intracranial hypertension. And then, as we had alluded to, there's an increasing prevalence, not just in the United States, but globally as a result of obesity. So how do we diagnose idiopathic intracranial hypertension? So strictly speaking, idiopathic intracranial hypertension is diagnosed by an opening pressure of greater than 20 centimeters of water in a non-obese patient and greater than 25 in an obese patient. So the criteria are a little bit different, but still both of these are obviously over the normal, 10 to 15 that we would normally see in normal intracranial pressures. That's sort of the strict diagnostic criteria. Now, a lot of these patients, and that's one of the questions I'll postulate to everyone at the end of the talk is there, which there does seem to be, a phenomenon that is somewhere intermediate between idiopathic intracranial hypertension and normal pressure hydrocephalus, where these patients don't have elevated intracranial hypertension, but they still have all of the sequelae of it. And I think that's something to keep in the back of your mind when you're seeing these patients. Another diagnostic, certainly not a diagnostic criteria, but a diagnosis suggesting a finding suggesting the diagnosis is an empty cella. So we'll basically see a collection of CSF or a subarachnoid sort of a cerebrospinal fluid collection on MRI. You can see changes in the globe, the posterior part of the eye. You can actually see edema of the optic nerve sheath itself. I just saw a patient last week who had all of these findings, but we have not done an opening pressure on her yet. And then finally, as I had mentioned, venous sinus stenosis. Sometimes patients will get an MRA or MRV to evaluate for the patency of their venous sinuses, and you can sometimes see stenosis. So how do I arrive at the diagnosis if I see a patient? A lot of times it's pretty obvious, especially in those patients that have a tube in place that you can see pulsatile clear fluid in the lumen of the tube. It's a pretty easy diagnosis, but clinical history, I think, is still, as with most diagnoses, very important. A CT scan, obviously, to show bony defects along the skull base. And MRI is more useful, not to see bony defects, but to see any associated encephalocele. Ophthalmology consultation. If I'm suspicious that somebody has IIH, we will send the patient to our ophthalmology colleagues to look for papilledema and even some visual field defects, which I've seen on a couple of occasions. And then more commonly in anterior skull-based defects, but these other imaging or diagnostic modalities, for instance, a cisternogram, a CT cisternogram, myelograms, and then radionuclide studies can be sort of adjuncts. This is a classic, this is the patient actually whose scout film I showed you earlier. You can see a fairly sizable tegmen mastoideum defect. Here you can see another tegmen mastoideum defect here, and this is a more medial approaching. Here you can start to see the ossicular chain in the middle ear, is the lateral semicircular canal. So this is a sort of in the mastoid antrum region. And then marching even more anteriorly and medially, you can see a couple of fairly large tegmen tympani defects here as well. This is an even further medial defect, essentially in the region of our petrous apex here. And then, as I had said, MRI is most useful for looking for encephaloceles. This MRI showed particularly because one differentiating factor, and she does have bilateral leaks, but was only leaking through an ear tube on the left. But I think this is a great example of the difference between somebody with a chronic serous otitis media from, let's say, eustachian tube dysfunction or allergic rhinitis. You see literally every nook and cranny of the mastoid is filled with fluid. You can see this both on CT scan and MRI, but you can see it's literally in every nook and cranny. You can see the dural division here, and I think that's just a sort of classic for a CSF leak. Here you can see an encephalocele. So this is a tegmen tympani encephalocele that was seen at the time of surgery. And then finally, this is, again, shows a little fluid in sort of every nook and cranny. I thought that I got a chuckle out of this MRI when we got it back. You can actually see she's draining so briskly that you can actually see an air fluid level in her conchal bowl as she's laying supine for her MRI. So that's maybe I can name that positive sign after myself. So how do we actually collect beta 2 do we actually collect the fluid to look for positive beta 2 transferrin? The answer to that is I've done this on a handful of occasions, but I rarely do. And the reason for that is usually, as one of my mentors used to say, if it walks like a duck and quacks like a duck, it's probably a duck. And I don't think it's always necessary to get a CSF for beta transferrin analysis. Of course, it's the gold standard, but it can be expensive, and you can also get false negatives from it. This is the way, if I'm going to collect it, this is the way that I do it. I actually will put 1 or 2 otic wicks in the patient's ear and just in their external auditory canal. And then I'll bring them back to clinic, 3, depending on how briskly they're leaking, bring them back to clinic 3 or 4 days later and put the wicks in a syringe, either one of these 1 millimeter or 3 millimeter syringes. And so take the plunger out, put it in the syringe, and then most of the time you can depress the plunger and get enough fluid out of the syringe to send for beta 2 transferrin. Again, you have to get it down to the lab right away. They like it to not be more than a couple of hours at room temperature and so forth. Some people will send patients home and try to collect CSF if they're actually leaking briskly enough from their ear. And if you have patients do that, they need to keep it on ice, not frozen, but just on ice to keep it cool or in the refrigerator. Finally, I think just in terms of the diagnosis, I think it's always a good idea just to perform a flexible nasopharyngoscopy to make sure that there isn't some kind of a neoplastic process in the nasopharynx that could be causing sort of an obstruction, an obstructive process. So how do we treat CSF leaks? So really sort of, I'd say, focus on these three approaches. So you can either do a transmastoid middle fossa or a combined transmastoid and middle fossa approach. A transmastoid approach has to be done if you see a posterior fossa defect. So if you're able to identify a posterior fossa defect on your preoperative CT scan, you're going to have to at least do a transmastoid or a combined approach. You avoid a craniotomy with it. You can also evaluate for concomitant a middle ear or a mastoid disease if somebody does have coexistent chronic otitis media. However, you have pretty limited access to the tegmen tympani. Contrary, a middle fossa, if you do a middle fossa approach, you can see the entire middle fossa floor, so you can see all the way from lateral, the tegmen mastoidium, all the way to the petrous apex. Requires an ICU stay, greater risk of neurological complications, obviously, because you're intracranial, not necessarily intradural, but at least intracranial. And I say, may require neurosurgery. I do these in conjunction with my neurosurgical colleagues. And the reason I do is, we always seem to learn something from one another when we do them. I like the collaboration. And also, unfortunately, knock on wood, I've never had one, but if you do have any postoperative, issues, epidural hematoma or so forth, then your neurosurgery colleagues are aware of the patient and they're on board. And another risk of neurologic complications, I've had a handful of patients, maybe 2 or 3, that have actually had some transient postoperative expressive aphasia. And again, that's just from the temporal lobe retraction, even though it's minimal. I've had some patients with transient postoperative expressive aphasias. Combined approach, a lot of people like to do a combined transmastoid and middle fossa. I would say we do 95% from a middle fossa alone. The only time we do a combined approach is if there's a very large encephalocele, or the patient has a history of a cholesteatoma or chronic otitis media that also needs to be addressed simultaneously. Again, there's advantages of a combined approach. You can see the posterior fossa defects and middle fossa defects. You can also sort of place, large multi-layer grafts, and you can confirm, really well the placement of your graft. So you may place the graft from the middle fossa side and then sort of confirm its location from the mastoid or sort of, looking up superiorly at the floor of the middle fossa. You can confirm the location of your repair. And then a subtotal petrosectomy. This I include it for completeness sake, but it's really not something that we use for patients with spontaneous CSF leaks. This is more of a after tumor resection, for instance, or occasionally after trauma. And the only time you're gonna do that is if somebody has poor hearing, has a really extensive chronic ear disease, or canal wall bound mastoidectomy, and occasionally in a situation with a really large encephalocele. But of course, it will result in maximal conductive hearing loss. If not done properly, you can risk cholesteatoma formation, and for that reason, a lot of times you'll need postoperative imaging, at least for a period of time. This is sort of a standard transmastoid and middle fossa incision that we use. So, normally is sort of your post-orbicular incision for a transmastoid, or excuse me, just for a routine mastoidectomy. And then we sort of extend that up into the frontotemporal hairline, so we can do a combined middle fossa and transmastoid approach. If we're not going to do a transmastoid, I've gone to using sort of this C-shaped incision because I think it causes the patient less pain than sort of the traditional middle fossa incision that actually has this pre-auricular component, and it's sort of this reverse question mark configuration. And then this is just another sort of alternative approach that you can use for a middle fossa incision. It's just sort of this lazy S that can give you adequate exposure here to the floor of the middle fossa. So the technique, that's sort of, that is the technique. And some people will say, there's a question of doing an intradural versus an extradural repair. One of the neurosurgeons I've worked with previously liked to do intradural repairs. We've had good luck with just simply doing extradural onlay repairs. Talk about the different layers that you need here in a second, but I think that's sort of the main branching point, is if you're going to do it extradural or intradural. This is sort of a picture of an intradural repair. So here is the dura obviously being retracted, and here's the brain. So you've actually gone into the you've gone intradurally, and you can see the defects here. You can actually see the bony defects where the arachnoid granulations had actually penetrated through the dura, resulting in a leak. So again, intradural versus extradural. How do we repair these? What do we repair them with? Routinely, we'll use fascia and the split calvarial bone grafts. Some people will use cartilage. We like to try to use autologous materials as much as possible. However, we do use allogenic materials such as DuraRepair, Duragen, Syntheseal, or one of the neurosurgeons I worked with actually use bovine pericardium. A lot of times we'll use dural sealants or fibrin glues such as Evicel, Tacil, Duraseal, or Adherus. Adherus is what we've been using most frequently right now. And then bone cement, Hydroset, or Cranios. Cranios is a reinforced product that is really easy to work with. It's more like a putty, and it doesn't get as runny and as moist. And then sort of the one, I wouldn't say controversy, but the one point where some people are very for it and some are against it is a lumbar drain. We don't routinely drain our CSF leak repairs. I think it's more of a technique or a strategy for anterior skull-based leaks than it is for lateral skull-based leaks, and sometimes in large part because patients with anterior leaks will undergo a fluorescein leak evaluation with intrathecal fluorescein. If you just mechanically speaking, if you don't put a drain in, theoretically you're going to have sort of more pressure and sort of a bath plug effect on your repair. Whereas if you have a drain in place and you're draining cerebrospinal fluid, it can actually pull the brain away from that graft and not allow sort of it to rest and sort of cause that scarring and that repair that you want to have occur. And oftentimes we'll consider, along the CSF sort of train, is after these patients are repaired, a couple of months after repair, we'll often send them to our neurology colleagues for a lumbar puncture to then look for elevated intracranial pressure. And the reason for that is a lot of times these patients won't have sort of a diagnostic elevated intracranial pressure that's within the elevated intracranial pressure category because they have a leak. But after you repair the leak, then they'll oftentimes develop and they'll reach that threshold to be considered elevated. Sort of the American saying of everything but the kitchen sink, I think, holds true. The overall failure rate for lateral skull-based repairs is quite low, only about 6%. And Lobo, in their systematic review in 2017, showed that, and Sava as well, showed a closure rate of 75% with single layer closure, but a closure rate in their study of 100% with multi-layer closure, and that included 3 or more layers. So again, fascia, a bone cement if you want to use that, Duragen, Dura Repair, and a split carbarial bone graft or cartilage. So the more layers, the better, I think, is sort of the conclusion there. So this patient, this is the patient I was talking to you about who had presented with a fulminant bacterial meningitis. You can actually see a little bit of intracranial air here right above the lateral aspect of the mastoid. You can see a small mastoid, tegmen mastoideum defect. Here's another larger tegmen mastoideum defect. And this was her CT scan. She actually had a small little tegmen tympani encephalocele as well. Just quickly, we'll just talk a little bit about, I'll just show you a quick video here of how we repair these from a middle fossa craniotomy standpoint. We usually center the craniotomy over the external auditory canal. You want a little bit more of the craniotomy over the mastoid as opposed to more anteriorly for a tumor resection, for instance. We elevate the dura up off the floor of the middle fossa, and you can see already the tegmen defects, the little pinpoint bony defects in the floor of the middle fossa. Here you can actually see a small little encephalocele. That's usually non-viable brain and is just bipolar. A lot of times you can bipolar the dura to tighten it up a little bit, and we'll drill down some of the overhanging bone. We'll drill that down to sort of get flush with the floor of the middle fossa, and we enlarge our craniotomy a little bit anteriorly. So again, this would be a left ear. So the petrous apex, we're elevating up towards the petrous apex now, and you can see. Most of the time you can see GSPN, greater superficial petrosal nerve. Sometimes it's tough to identify it just because the dura is so sort of friable, but usually you can identify it. We usually obtain hemostasis with a thrombin, something called flow seal, gives good this sort of venous hemostasis. And then our first layer is usually that of a piece of Duragen. And again, the important aspect here, I think, here you can see this pretty large tegmen mastoideum defect laterally here. I think the important point here is to get this tucked as anteriorly as you can and also as medially as you can, all the way down to the true petrous ridge, at least down to the superior petrosal sinus. And then we usually tuck it underneath the edges of the craniotomy, again, just to hold it secure and in place. And then sometimes we'll place another layer of a Dura Repair, which is a little bit stiffer allogenic material. But here we just, we're placing the fascia, the large piece of temporalis fascia that's harvested at the time of incising the temporalis muscle to elevate it. And again, this is tucked in a similar fashion as posteriorly and as anteriorly as possible. And here again, you can see these pretty large tegmen mastoideum defects here. And then finally, we take a split calvareal bone graft. So again, this is a piece of bone that is split along the diploic space from the middle fossa craniotomy bone flap. We split it with a sagittal saw, and then we can lay that down. Usually you can get a couple of pieces. So we laid the one piece over these more medial defects, and then there was another more anterior defect over which we also laid a piece of the split calvareal bone graft. And then this patient had a nice thick bone, so we were able to apply yet a third piece of split calvareal bone graft. And then this is the adherous dural sealant that we use at the completion to sort of seal the entire repair after we've applied all the layers. And then of course the replacement of the bone flap and closure. So this is a postoperative picture of that patient. You can see the one of the split fibrotic bone grafts here laying along the floor of the middle fossa. Again, she had, as you could see in that video, she had a meningocele in her tegmen mastoideum and then a tegmen tympani encephalocele. And this bone graft, you can see these stay in position fairly nicely and can be seen nicely on any postoperative imaging that you get. So treatment failure. So why did these fail? And I alluded to this a little bit earlier, but usually it's from it's technical error or more importantly, I think failure of identification where the leak is coming from. And here in these top two images, you can see this posterior fossa defect that if you were paying attention just to the coronal images, you wouldn't see. You can only see these posterior fossa defects on the axial images. So this is an axial image. This is a sagittal image. Here again is that leak. And then on these bottom two pictures up here in the petrous apex, so here's the internal auditory canal, malleus and incus, semicircular canals. Here's the petrous apex, and you can see a defect in the petrous apex here. And there's a good picture out of one of the neurosurgery, or a good article out of one of the neurosurgery journals about the different pathways of CSF flow into the middle ear. But it of course can go from petrous apex through infralabyrinthine or supralabyrinthine air cell tracts. And so all you have to do is just have a hole somewhere, and that fluid is going to find its way into the middle ear. And again, here you can see this cephalocele or meningocele here that's confirmed along with this petrous apex defect. You can see that on T2 weighted MRI. So in summary, I think you have to have a high suspicion for cerebrospinal fluid leaks in the appropriate setting. I would encourage you to think of this often and early, especially in patients who are obese or have other setups for spontaneous leaks. Again, you can really make somebody's quality of life a lot better by stopping chronic drainage from the ear and improving their hearing by repairing one of these spontaneous leaks. We belabored the point of a strong association with obesity. We talked about the different ways these can be repaired. I don't think there's one single way. I think a lot of it is just what works in your hands. And then this is a question that I posed to you on one of the slides as far as what are the sort of diagnostic criteria. Is there a clinical entity that exists somewhere between idiopathic intracranial hypertension and normal pressure hydrocephalus? So in normal pressure hydrocephalus, people don't have elevated intracranial pressures, but they usually don't have leaks. And then with idiopathic intracranial hypertension, these patients oftentimes have leaks, but they don't always have elevated intracranial pressures by lumbar puncture criteria. So I think there seems to be some sort of something in between. So anyway, thank you everybody. This is my son Henry and my wife Megan. So thanks guys for your attention. I appreciate Richard very much, you allowing me to participate in this, and look forward to doing some more lectures later at another time.
Alex, this is Nestor here.
Hey Nestor.
How are you?
Good, how are you, man?
I'm good. I would like to ask you something. Do you have any experience using dye like fluorescein or injecting on the subarachnoid space? Because here in Paraguay, we haven't got the transferrin test to do the cases where you are not sure if it is like a serous otitis, or if it is a leak, or if the patient is not leaking through the ear, but it does through the nose, to be able to, it also allows us to locate where the fistula is. So do you ever use the fluorescent dye or something like that?
Truth be told, I never have for a lateral skull-base defect. We did in my residency, and some of my rhinology colleagues will occasionally use it for anterior leaks. And I think where it comes into play is, like you said, where, people are having, let's say, postnasal drip or a salty metallic taste in the back of their throat, and you don't know if it's coming from a lateral skull base defect, especially if they have, otorrhea through a tube, or whether it's coming from an anterior defect. And I think fluorescein studies can be helpful in that situation. I'd encourage you to get with your radiology colleagues, but mainly what happen, you can do a radionuclide tracer where you put pledgets up in the nose, and then you can send the pledgets to see if they have a radionuclide activity. You place the pledgets usually in the operating room, and then it's through a lumbar puncture they are administered a radioactive radionuclide, or you can do, again, also through a lumbar puncture and a lumbar drain, you can place fluorescein. The biggest risk with that is, there are certainly reports of seizures. Fluorescein is not technically supposed to be used in the intrathecal space, but I know my rhinology colleagues will oftentimes do that if they're not exactly sure where the leak is coming from along the anterior skull base, and you can certainly do that intraoperatively, and then be looking through the nose. And of course, if you have a brisk enough leak through a lateral defect, you'll see the fluorescein come out of the eustachian tube. But if it's an anterior defect, of course, you'd see it come from somewhere along the ethmoid roof or the cribiform area.
Thank you, Alex.
Yeah.
I got a question for you. I guess it's a multiple question. It's about CSF pressures preoperatively. Do you routinely check CSF pressures preoperatively in your patients? Do you know how to have CSF?
I can barely hear the question.
Okay, my question is this. You routinely check CSF pressures on patients preoperatively?
Do we routinely test them preoperatively?
Yes.
No, we don't. And again, some of that rationale is, first of all, it doesn't, in a lot of ways, it doesn't matter if they have it elevated preoperatively or not. They have a leak, so we're gonna repair it preoperatively regardless. But also, if somebody does have IIH and they have a leak, especially if it's a brisk leak, you may do a lumbar puncture on them, and their lumbar puncture may be normal, and it won't be abnormal until the repair has been completed. At some point, in the postoperative period, you wait 2 weeks, a month, or a couple of months. So we will test these people postoperatively, but we don't necessarily do it preoperatively, because there's just really no. I don't think it's going to give you an accurate reading, and it also doesn't really change your management.
I agree with that. Just one question. Of your patients postoperatively, when you test them for CSF pressure, what percentage of them show after repair of the leak elevated CSF pressures?
I'd say probably about 50 to 70%. I couldn't give you an exact number, but that's where I bring up that last slide is there some kind of something in between NPH and IIH? Because some of these patients, again, coming back to obesity, some of them are morbidly obese. At the time of repair, the floor of their middle fossa, it looks like Swiss cheese. But then, a couple of months after the repair, and after you've clearly shown that the repair is intact, you'll do a lumbar puncture and they don't have elevated ICP. And so I think there's got to be somewhere in between. We've even done lumbar punctures on people that have preoperative evidence of papilledema, and they don't, and on their postoperative LP, they don't have, it's not pathologically elevated. Now, is that a function of a poor LP, poor positioning? I don't know the answer to that. But another thing I mentioned is just mentioned the presence of a tube. If patients, which they usually do, present to me with a tube, with CSF otorrhea, I usually leave the tube in place. I don't pull it at the time of surgery. And the reason I do is it's sort of a litmus test. It's a litmus test to show you if you got the leak stopped or not. Because if you leave the tube in and, 2-3 weeks post-operatively, their ear is dry, then you've proven to yourself that you stopped the leak, at which point in time I'll often just pull the tube in clinic and perform a little paper patch.
Okay. Another thing is on your list, it showed that American Samoa has almost 40% incidence of obesity for the population, if not higher, with significant cardiovascular disease and associated diabetes. It would be interesting to see, because you've been there and I've been there multiple times. I've yet to see anybody present with meningitis that's had a tegment defect and spontaneous CSF otorrhea. And I guess my question is, of those patients who present with meningitis in American Samoa, how many of them really have this pathology, but yet it's overlooked and they're thinking that the meningitis is, from some other cause?
Right.
That would be a very interesting thing to look at.
Yeah, you could retrospectively look at it, because I'd imagine all those patients got a CT scan.
Right. The question is, and they should have a CT scan of their head. So that would be I'll talk to the people in American Samoa. That would be something to do. Pull everybody for like 5 years, pull everybody who had meningitis and see what their head CT showed of the temporal bone.
Yeah, and then see how many of those patients got ear tubes. I imagine they probably got a tube put in at the time if they had evidence of an acute otitis media.
No, probably what happened is they died. They either got better from their meningitis or died, and it was never addressed. They probably never treated from an ENT perspective.
Right.
All right. Listen, anybody else have any questions?
Yeah. Hi, Dr. Alex. Would you consider using fascia lata for the repair?
Yeah, absolutely. For some of our really, really big repairs, I have never used it, but I know our neurosurgeons do. They use it especially if you don't, if you don't have any pericranium left. But I think in large part they prefer to use pericranium if it's available, if the patient hasn't had previous craniotomies and so forth. But the fascia lata it obviously introduces another surgical site, more morbidity, and usually you really don't need much more than you can get from a big piece of temporalis fascia. And plus you have other allogenic materials like I mentioned, the Duragen, Durin Repair, and so forth. And so I think I've never used it, but I know that the neurosurgeons do for certain, especially big anterior cranial fossa repairs.
Yeah, you could also use biodesign, which you're familiar with.
Yeah.
All right. Well, listen, if nobody else has any questions, I want to thank Alex for a very informative talk. I mean, this is a interesting subject. He lives in a place where for some reason it's kind of more endemic. I mean, he's seeing 20 cases a year of this, he says. And it's a fascinating subject. I guess in another 10 years, Alex will have the largest case study in the world and be a true expert and consultant on this. So, Alex, listen, thank you for your time. If anybody has any particular questions, just put them on the platform. Alex will respond to us accordingly. And this is being recorded. So if anybody wishes for the recording, please notify me on WhatsApp. And again, thank you, Alex. Appreciate your time today.
Thanks, Richard. Have a good day, everybody.
Bye-bye.